Sunday. So I'm going to talk today about testosterone, which is a female hormone as well as a male hormone. Something that a lot of people are asking about and not know much about. I have done an Instagram live before about it, but I'm going to do it again, and I am really shocked with the number of questions that people have sent. It's wonderful that so many of you are asking questions, but actually I feel really sad that so many of you are struggling to receive the right help, advice, support and treatment. It's also really topical that I chose testosterone as a topic, and we choose the topics for Instagram Lives with my team in advance so we can prepare resources that we're going to give out on my Instagram Live. But some of you, certainly in the UK, might have seen this, which is in the Times, the Sunday Times today. And it's actually a big article, great for women, but men are spoken about too, of course. But it actually says, testosterone top-ups are giving even women a lift, even women. Still a bit of misogyny there, but still, it's just important that we're starting the conversation. And I was delighted to be interviewed by the journalist, and some of my quotes are here actually, and I am quite vocal because I say it's outrageous that it's so difficult for women to receive their own hormone. So it's worth a read of that, but I thought I would just start with some really basic information about testosterone. Even the name is really triggering. Testosterone, testis. We don't have testes, do we? Men do. But actually testosterone, even in men, is not just produced by the testes. It's produced elsewhere in the body. But in women, we don't have testes, of course, but we have ovaries. We also have our adrenal glands, which are the main sources of testosterone. But testosterone is also produced in our brains. So it's actually manufactured in our brains. It's also made in our muscles and also our bones as well. But the important thing about testosterone is it's a hormone. Like lots of hormones, they're chemical messengers that go into the bloodstream, and our bloodstream takes all the nutrients in our bloodstream to every single cell in our body. Our circulation's amazing. That's what it does. Our blood pumps the blood around our body, and there's no stone unturned. Every single cell is reached, which is important because every single cell, whether you're a man or a woman, actually responds to testosterone. We're no different in the way our hormones respond. The amounts of hormones we have are different. So in men, they have on average between 7 and 10 times more testosterone than us. But actually when we're younger, so in our sort of early 20s, on average, not that any woman's average, but just as a generalised sort of statement really, when we're in our early 20s, as women, we produce more testosterone than estrogen. I'll say that again, we produce more testosterone than estrogen when we're younger. And testosterone is actually the most biologically active hormone that we have in our bodies. I'll say that again. It's the most biologically active hormone we have in our bodies. In our bodies, not in our ovaries, not in our womb, not in only a very small area of our brain, everywhere, all over our body. And when testosterone was discovered as a hormone in the 1940s, the experiments initially were done on male and female. And then, as many of you know, a lot of the studies forgot about women. We were too confusing, and we still are because of all our other hormones. So a lot of research is done on a 70-kilogram man. Now, there aren't many 70-kilogram men, but actually they forget about the role of testosterone in the women. But there's been a huge amount of studies looking at the role of testosterone in men, because without testosterone, there are some problems which I'll talk about in a minute. But biologically, we are exactly the same. So the way that our cells work, the way all these chemical reactions work within our cells to allow all our cell processes to work throughout our body, are essentially the same whether we're male or female. We've done this chart, which some of you might have seen, and I've put on my stories, called The Influence of Testosterone. Now, it's really actually dumbed down. We've just grouped some different areas. So we've got eye, heart, the circulation, mood, muscle, metabolism, bone health, bladder. We've just picked some salient areas which we think will be worth just really starting the conversation, but we absolutely can't list the thousands of processes that are involved with testosterone, because it is involved in lots of chemical reactions in our body, but also in our brain as well, and that's really important when we think about what it does when we don't have it. So with testosterone, levels actually decline as we get older, and generally speaking it declines with age, and there seems to be a little bit of an upturn actually as we get older. But if you think about how testosterone is made, I've said before, our sex hormones are made from cholesterol. So cholesterol, there's good and bad cholesterol, but the good cholesterol helps make our cell membranes. It's like a building block for our sex hormones. So cholesterol gets broken down into progesterone. Progesterone, which men have too, by the way, goes into testosterone. And then testosterone gets aromatase into estradiol. And some of you might have heard of the enzyme aromatase, because when people have had breast cancer, some women are given an aromatase inhibitor, and that blocks the aromatization of testosterone to estradiol, and I'll try and remember to come back to that bit later. So testosterone, you need that to form estrogen, which is really interesting, isn't it? Because we always think estrogen's for the women and testosterone's for the men, but of course not, because we need testosterone in our bodies, and testosterone is part of the pathway of creating estradiol, which is the good form of estrogen. So we have this enzyme aromatase in our bodies, but especially in our brain actually. Aromatase in the brain is very active, and it's very good at aromatizing testosterone to estradiol, because estradiol is very good in our brain as well. So testosterone has lots of roles all through our body. Every single cell, as I say, has a receptor that responds to testosterone. So when we look at symptoms of testosterone deficiency, there are many, and it's a bit like symptoms of estrogen deficiency. There are many. It doesn't mean we all have to have every single symptom to be testosterone deficient, and it doesn't mean that we have to have a certain number or have them for a certain length of time or have them on a certain day of the month. We are all individuals and we are all different. The same as like if we are stressed, stress can affect us in different ways. If we had raised blood pressure, we would have different blood pressure readings and we might have different symptoms. If we have, I don't know, anything, a chest infection, we'll feel differently to others. So individualisation of treatment is important, but actually listening to people, experiencing and listening to the stories that they tell might be different to others. But as a generalisation, there are lots of symptoms related to testosterone deficiency. Everyone talks about reduced libido, and that is important. I'm very open about talking about sex. Sex and libido are really important whether we have partners or not. But actually, if we look at Freud's definition of libido, it wasn't just about sex, it's about enjoyment, pleasure of life as well. So looking out of the window and the sun is shining, our libido is better, we feel happier, we feel more joyous, we can enjoy things. That tingling feeling when you go to a music concert or something exciting happens, that is part of libido as well. So I feel very strongly as women or men, or we're not just sexual objects. Sex is important, and how we feel and enjoy sex, of course, is important, but it's about pleasure of life. So a lot of women who are testosterone deficient say they just feel joyless, they feel emotionless, they feel quite numb, they feel that they're just existing, not living. Someone said to me a while ago, their zest for life has gone. Someone told me in my clinic last week that I don't know who I've become. I'm not the person that I was. Very hard to sort of like write in a tick box, yes or no, are you feeling like this? But just feeling a bit, ugh. Like sometimes my children text me that CBA, can't be asked. It's like that, oh really, it's another day. I really can't be bothered. There's nothing that's enjoying what I do. And so that's quite a sort of difficult thing to quantify, but it's something that a lot of women experience. And I know it's related to testosterone because I've excluded other medical causes. There's nothing else going on in their life to explain why they feel like that. And most importantly, when they have testosterone back, that joy comes back, that energy, that motivation comes back. So it's not difficult to understand. But also, if you think, why is it happening? Well, we have cells that respond to testosterone all over our brain. and in the pleasure area of our brain. And we don't just have, testosterone doesn't just work in one area that gives us pleasure for sex, it gives us pleasure for other things, but also it lights up areas of our brain that affect our personality, our memory, our concentration, our sleep, our even the way that our muscles move, the way that our heart beats is controlled in our brain. And those areas in our brain are stimulated by testosterone, as well as estrogen and progesterone as well. So really, really important that we don't think about testosterone just affecting one area of our brain that determines libido. It affects all areas of the brain, and as I've shown you in pictures before, that when testosterone stimulates our brain, it often lights up a bit like a Christmas tree. It helps the way that our brain functions. It reduces inflammation in the brain. It helps the nerves work. It helps rebuild the myelin sheath, which is like the conducting sheath, outside layer, if you like, of nerves. So it can help nerves fire off better, work better. So it regenerates a lot of our brain function as well. So if you know that, then you'll probably be thinking about, well, what other symptoms of testosterone deficiency are there? Well, there can be low mood, there can be anxiety, there can be poor sleep, there can also be palpitations as well. It also can affect the thermoregulatory part of our brain. So some people get flushes and sweats, which are due to testosterone deficiency, not just estrogen deficiency. And then people, sometimes there's something where people often feel very lightheaded when they stand up quickly, and that can be related to low testosterone as well. These very dark, intrusive, negative thoughts, the rumination that can occur, the obsessiveness that can sometimes occur with women, can be related to low or changing estradiol levels, but often can be related to low testosterone levels as well. So there's a myriad of things, brain memory, concentration as well. Also this sort of inability to think properly and clearly, the difficulty to recall names or objects, or like shopping lists, or you go into a room and you think, oh, I don't know what I've come in for. Obviously that can be due to lots of things, but it's quite commonly related to low testosterone as well. And then elsewhere in the body, it's not just about our brain. I've already said testosterone affects every cell in our body. So people can have dry eyes, really common actually. Sometimes they feel dry, but actually sometimes they water a lot. And that can be related to low testosterone affecting our meibomian gland, which is what produces our tears. And then people can get muscle and joint pains, very common testosterone deficiency symptom as well. And testosterone can affect our skin and our hair. A lot of people have asked me about hair loss or changes with testosterone, but actually when people have low testosterone, many people find that their skin is dry. They often find that their nails break or become thinner, and often find that their hair loses its texture and shine as well, and even can reduce hair growth or make hair more brittle. And then the other area that can be really commonly affected with low testosterone is our bladder and pelvic floor and vagina. So it's not just our clitoris. A lot of people find that their clitoris shrinks. It's not so easy to stimulate the clitoris, but also it's all the surrounding tissues. So vaginal dryness, soreness, irritation, vulval changes. They're not just related to low estrogen, they can be related to low testosterone as well, because we have testosterone receptors in cells all around our vagina, vulva and pelvic floor. So people might find that pelvic floor exercises aren't working, or they're getting some urinary frequency or incontinence, and that can often be related to low testosterone. Also, recurrent urinary tract infections. A lot of women, it can be related to low testosterone as well. So important to think about testosterone affecting our whole body as well. And then the same as estrogen, and I've mentioned before, menopause is not just about symptoms. And when we talk about testosterone, I'm not really convinced it should be spoken about was related to menopause, because I've already said hormone levels decline with age. And for some women, they might have low testosterone before they have low estrogen. And so if their testosterone is lower on its own, they might be having very regular normal periods, but still have low testosterone. So for some women, I think the testosterone deficiency is firstly more of a problem, but also secondly can actually manifest earlier than estrogen deficiency. And it's very hard because so little research is done into this. The area where it's more apparent and is more related to menopause is when women have a surgical menopause, because I've already said a lot of our testosterone is produced by our ovaries. So if you were young in your 20s, 30s or even 40s and have your ovaries removed, obviously your estrogen level will drop overnight, but so will your testosterone. So a lot of women who have had a surgical menopause or even a menopause at an earlier age because the ovaries have stopped working for whatever reason are more likely to be testosterone deficient quicker and at a younger age. But generally for many women, testosterone deficiency is not really related to menopause, and I think it should be seen as an isolated thing. A bit like if someone has iron deficiency and they've also got an underactive thyroid gland, you look at the two in isolation. Or if they've got type 1 diabetes, so insulin deficiency, and hypothyroidism, thyroxine deficiency, we manage and treat them separately. And that's the same, I think, for estrogen deficiency and testosterone deficiency, because they are different. They're independent hormones. They affect our cells in a different way. And so some people respond quicker and better to testosterone than they do to estrogen. So in addition to symptoms, whether a woman has symptoms or not, if she has low testosterone, then there's an increased risk of diseases the same as there is in the menopause. So we know that low levels of testosterone, and there have been some good studies about this, so low levels of testosterone in women have a higher incidence of heart disease and also dementia and osteoporosis. There's more evidence in men that show that low testosterone in men is associated with these inflammatory conditions. No surprise, because testosterone is very anti-inflammatory. So the longer we have without our anti-inflammatory hormones, the greater the risk of having inflammatory conditions. So it's not rocket science. You know, some of it is so frustrating. It's so frustratingly obvious that we have to justify our testosterone deficiency to try and enable us to have our natural hormone back. And this is what frustrates me so much. So we're looking at symptoms and we're looking at health risks as well. And this is really important because we're living longer. As a nation, women are living longer than they ever used to. So we're living longer without our hormones. And unsurprisingly, we have an increased incidence of all these diseases the older we are. So it's not just looking at symptoms in isolation, but if symptoms are affecting people, we need to try and help them. And as I've said many times before, I went into medicine to help people feel better. Is it bad that we want to feel better? Absolutely not. But more importantly, is it bad that we want to be healthier as well? No, I don't think it is either. So to be able to feel better and be healthy and reduce risk of diseases is absolutely game-changing for a lot of us. So then let's look about how do we give testosterone and what do we do? I've just spent a long time on purpose telling you about what testosterone does in our body, because I think if we're going to take any treatment, medication, hormonal treatment, we need to know what we're taking it for, why we're taking it, and what it's going to do in our body. So when we give testosterone, it's just the same biochemically as the testosterone we produce when we're younger. So it's not really a medicine, it's just a hormone replacement or hormone supplement, whatever you call it. It is just the natural hormone, but it's obviously being chemically made. It's derived from soy and yam plants, but biochemically it's exactly the same as testosterone that men and women produce when they're younger. So that's just to reassure you. We usually give it through the skin as either a gel or a cream, because like with estrogen, if it goes through the skin, it then goes straight into the bloodstream, which then is carried all around the body and can help every other cell. If testosterone is having as a tablet, which I never prescribe, it gets metabolized by the liver, which isn't a good thing really. So we don't ever prescribe it as tablets. I know men can inject testosterone, but I've never given anything other than the gel or the cream as testosterone for women. Now, how do we know we're testosterone deficient? And this is a big $1 million question really, because, you know, I could be feeling tired, low, reduced energy, poor sleep, muscle and joint pains, and it could be due to lots of different things. How do I know it's related to testosterone? Well, as a doctor, I exclude as many other conditions as possible. And often, like, women know as well, and often we know that the older we are, the more likely we are to be testosterone deficient. But there isn't really an easy blood test to just go, yes, you definitely are, or no, you're definitely not. In the clinic, in Newson Health Clinic, we tend to do baseline testosterone blood tests. Not always. If someone's had their ovaries removed, or they're older and they're exhibiting many symptoms related to testosterone deficiency, we don't always do it because it's always low. But a low testosterone doesn't even mean that all those symptoms are due to testosterone deficiency. So we want to keep our inquiring minds as physicians open and make sure we're not missing something else. So a baseline level can be useful, but testosterone is bound to proteins in the blood. And so we often do something called SHBG, sex hormone binding globulin. And what you do is you work out the ratio of the testosterone to sex hormone binding globulin, make it a percentage, and then you see what the percentage is. Now, what's really confusing about testosterone is that different labs will have different techniques of measuring the testosterone, and they have different normal ranges as well. When you look at the evidence as to how have they got these normal ranges, there isn't really good evidence. A lot of it is a bit of guesswork. So we don't really know what is normal. Like, my level of testosterone when I was 20 to my level when I was 40 is going to be different. And is it normal for me at 20 or normal at me at 40, and what would that be? And what would it be compared to a friend of mine who's the same age? It's impossible to know because we haven't done any studies. But we also know that testosterone levels change all the time. They change according to what we're doing, whether we're stressed, and we don't know, like, the level in our brain. Is that the same as the level in our blood? Is that the same as the level in our bladder? Probably not, because the way it's absorbed is different as well. So there's lots of uncertainties, and that's why we don't just hang everything onto a blood test. Often in medicine we do what's called a therapeutic challenge. So we will try a medicine and see if it helps. So if I went to the doctor, for example, with worsening migraines, they're not going to rush and do a blood test because that's not going to help with migraines, and they're not going to rush and do a brain scan. They're going to take a good history and say, well, Louise, you've tried XYZ drug, I'm going to give you A and maybe B drug and see if that helps. Come back in a few weeks. If you feel better, you can carry on. If not, I'm going to try C or D. And it's always about trying and seeing based on the symptoms that somebody is exhibiting and the evidence that we have. And we always have a diagnosis and a differential diagnosis, and we just go through the list and talk to the patient as well and say, well, would you like to try this drug A, Louise, that might have this side effect, or this one B that might have limited evidence, but it's probably safer than this one. And as a consenting adult, I choose. I can involve in my consultation with my doctor and decide what's best for me at that time with my migraines. So I'm using that as an example, but that's the same with testosterone. Often I'll say to patients, I don't know, I can't guarantee that you're going to improve with testosterone, but a lot of the symptoms you're telling me, the joint pain, the low mood, the poor sleep, the reduced memory, the brain fog, the reduced stamina, the low libido, I think probably are related to testosterone. So we can try it and see if you feel any better. If we look at the guidelines, so we've got the NICE menopause guidance, we've got International Menopause Society guidelines. They say that we can consider testosterone if women have reduced sexual desire despite being on HRT. Some guidelines will say women have to be severely psychologically distressed with their reduced libido before trying testosterone. I have a few issues with that because, firstly, as I said at the beginning of this, I don't feel libido is just about sexual desire. And secondly, I don't feel morally or ethically that it's right for a woman to be severely psychologically distressed for something until I offer them treatment, which may help and is also safe. The guidelines are there to help, but they are there to guide. We are all individuals and we can make decisions whether we would like to try something or not. based on limited evidence, because there's very limited evidence about testosterone in women because it's not been done. But there's a lot of evidence about what testosterone does in our body and our brains, how it works as a biologically active hormone. And there isn't any evidence to say that testosterone is dangerous when it's given properly. So the important thing is to see someone who understands, who's got a lot of clinical experience in prescribing testosterone as well. And we often see people in our clinic who just want to talk about testosterone. They might be on HRT already, and we actually do a cheaper, shorter consultation. It's called a TQS, Testosterone Quick Start Consultation. For those women who just want to discuss, could testosterone be an option for me? We arrange a blood test, we follow them up. But it's important, the following up bit as well. So there are two, in the UK there are two options. There's the testosterone gel, which is also available on the NHS because it's the male testosterone. Of course, men are allowed to have testosterone prescribed for them as a regulated licensed product. But guess what? Women don't have a licensed product of testosterone. We don't in many countries. In Australia they do, but most countries we don't have a licensed product. Because it's not licensed doesn't mean it's not safe. It's still a regulated product. So we prescribe also the cream, which is available as a licensed preparation in Australia, but we can prescribe it off license, but it has to be privately, so people do have to pay for it. It is going through the MHRA now, and I'm hoping, we're really hoping, that later this year it will be approved, which means it will be licensed. So then theoretically, and I say theoretically, it will be available through the NHS. But the testosterone gel is available through the NHS, but there's a lot of GPs that still can't prescribe it because their health authority, like their board if you like, their health authority, have said that women have to be referred to gynecologists before they can be considered for testosterone, which I think is absolutely awful in my mind, because testosterone is one of the safest things I've ever prescribed. It's far safer than antidepressants. It doesn't have the long-term risks that antidepressants do of bone loss. Osteoporosis can occur with antidepressants, and also antidepressants, there was an article actually in the paper today again about how they can be quite addictive, and a lot of people find that they feel quite brain dead and numb if they're not clinically depressed and given them. So you could argue, and testosterone is a natural hormone, so testosterone is safer than antidepressants, yet a lot of women are given antidepressants instead of testosterone. So some GPs aren't allowed to prescribe it, some don't feel confident in prescribing. Obviously we've got our Confidence in the Menopause course, which does discuss about safe prescribing of testosterone. So when we give testosterone, we usually give it for 3 months, and we decide whether to use the gel or the cream, and sometimes people absorb the gel better than the cream or the cream better than the gel, so that's more of a personal preference. We review people after 3 or 4 months, and then we usually do a blood test to see how it's been absorbed. But again, we only look at that in conjunction with how a woman's feeling. So if a woman's starting to feel better, and a lot of women, certainly after 3 to 6 months, if their symptoms are related to low testosterone, say, oh my goodness me, I just feel clear again, you know, everything's in colour rather than black and white, I'm enjoying my life, it's easier, my job's easier, everything's easier, and my symptoms have improved, then even if their level had come up a bit but it was still low, I wouldn't change their dose because it's right for them. But if their level was low and their symptoms hadn't improved, that's when we might advise to increase the dose a little bit and then repeat the level and see. There are some women that have a higher level, and a lot of people have messaged me to say, what happens if you have a high level? Well, it really varies in the way it's absorbed and metabolised, and also we're producing testosterone often ourselves. So I will share on my stories after, but and I put it on my grid, I'm pretty sure, before, that I did testosterone levels on one of our patients 8 times in a day, who's very stable on her testosterone. And throughout her day, her level went from being very low to quite high without any change of anything. So again, it depends on the time a blood test is taken, what else is going on in that person's life. So if someone has a high level but they're feeling well and fine with no side effects, then we usually repeat the blood test in a few weeks' time. So just have the blood test with a bit of a pinch of salt. Some of the laboratories I see in the NHS, the testosterone levels are set quite low, like 1.2, 1.3, which is very low actually. So it's not just about a blood test. So if someone tells you your blood test is normal, ask to see the number, because I've seen people with testosterone levels of less than 0.2, i.e. they've got no testosterone, and the computer says normal because the computer is only set to look if it's a high level of testosterone. So get the actual number, but just reflect and think, do you think it could be related to low testosterone? And if it is, then it's worth seeing someone who understands testosterone, is confident in prescribing, will monitor you closely, and then you can have this therapeutic trial and see. Now, the other thing that I was going to say about testosterone is there's the people that sort of seem to be very anti-testosterone, doctors as well, are very worried about side effects. Now, anybody can get a side effect of anything if it's used too much. If it's used in the right way, it's very unusual to get side effects. So there are theoretical side effects and real side effects. The real side effects women often get with testosterone is some hair growth where they rub it in. So it's usually rubbed in on the thigh or the bottom. And people can sometimes notice they get a bit more hair growth because it can stimulate the hair follicles where it's been rubbed in. That does not equate to having a beard or a moustache or hair on your arms or anywhere else at all. And so if you do get a bit of hair on your thigh and you're feeling great, it's not the end of the world. If you get systemic hair growth, it might be an indication that you're using too much. But side effects are reversible, which is really reassuring. Some people feel a bit more sort of wired and highly strung when they start it, especially if their level's very low, because their body's thinking, gosh, what's going on? And those women, we often reduce the dose, and maybe they just use it every other day initially. So you can tailor it for the individual. Other people talk about side effects such as voice changes or clitoromegaly, which is enlargement of the clitoris. I've seen people whose clitoris has shrunk a lot because they've had low testosterone, and then their clitoris has returned to how the size it used to be. I don't see people with really massive clitoris. It's not, I've never seen it. And that's maybe if people were using very high doses of testosterone, that would be a problem, but I've never seen that. Voice changes, I've seen one lady with a voice change, and she went to a private clinic in London who didn't really know what they were doing, and she was on too high a dose for her. And she came really worried about her voice. We've since reduced her testosterone right down, but also she was on too low estrogen as well, because our hormones all work together. So she's now on adequate estrogen, a low dose of testosterone, and actually her voice has come back to normal. And she's very sensitive about her voice because she's a singer. So she is really reassured. So and so side effects, like I say, are usually reversible, but they're vanishingly rare actually. People worry about hair loss on testosterone, but actually hair loss and hair changes can occur quite commonly to women in their 40s and 50s for other reasons. So if you are getting hair loss and you're using testosterone, it's worth seeing a hair specialist. You might know I work very closely with Dr. Saj Rajpar, Midland Skin, who's amazing at making sure that there's no other reason for hair loss, and usually it's not related to testosterone. And he agrees and says actually that testosterone actually systemically in women can improve hair growth for most women. So it's just something to be reassured of as well. So lots to think about. I think I've answered all your questions. I made some lists, made some notes, went through them all before I joined this tonight. The most important thing is to really just stand up for yourself. If you can't get testosterone and you want it, if you don't want it, it's fine. But if you wanted to try it, think about talking to your doctor. If you get nowhere with your doctor, some people do have to go privately. We see people in our clinic who just come like once or twice, usually twice for a review, and then quite often the GPs are more confident for taking over the prescribing then. We're really hopeful that testosterone will be licensed for women this year, which will be really amazing. We're also doing some really good research. We've done a little bit of research looking at our data that we published and presented at a European conference last year, showing that the mental health improvements of testosterone were more significant than libido improvements. We've been writing up more of our data, and we're just submitting it to publication, and we're doing some big research with another university, which I can't mention yet, but when I do, you'll all be really pleased and reassured as well. So there's a lot going on. Obviously we need more research, but in the meantime, what do? Let women suffer or let women have their own hormone back? And I think the latter is more appropriate for most of us. So find someone that understands, get lots of information. I will drip feed some information through. There's information also already on the Balance app and on our balance-menopause.com website. So I hope that's been helpful. I will post this on my grid now, and I look forward to seeing you next week. So have a good week, keep positive, keep empowered, and I hope that you feel buzzing with information now. So thanks for listening.